Access isn't bad. We're improving access to care. Let's not go backwards.
Welcome to Thriving with ADHD, a podcast where we'll share everyday practical tips to thrive in life as an adult with ADHD. This podcast is brought to you by Animo Sano Psychiatry, a behavioral health practice with a specialist ADHD clinic based in North Carolina. And this is your host, Nada Pupovac. Welcome to Thriving with ADHD, dear ADHD community. And welcome to the new season. Before we jump into today's conversation, I want to sincerely thank each and every one of you for listening to our show. We hope that the show has been helpful in managing your life with ADHD. This month, we are exploring some of the most pressing topics in the ADHD community at the moment. The sharp rise in adult ADHD diagnoses, the role of telehealth in improving access to care, and the potential impact of new prescribing regulations on patients and providers. Our guest speaker is Dr. Mina Boazak, the founder and medical director of Animo Sano Psychiatry. Mina is a psychiatrist and a thought leader in ADHD space who is passionate about expanding access to quality mental health care. His work focuses on balancing clinical excellence with practical solutions for patients navigating the challenges of ADHD. Welcome back to the show, Mina. I am delighted to have you with us again. As mentioned in the intro, rising ADHD diagnosis, as well as telehealth and online prescribing regulations, are the hot topics in the ADHD community at the moment. And I feel like there is no better person to explore this subject with than you, as Animo Sano's founder and also thought leader in the ADHD space and psychiatry in general. So welcome back, and I really can't wait to dive into the questions with you.
Thanks, Nada. That was a really kind introduction. I will say to anyone listening what I usually have in presentations that I give to different groups, which is just like Jon Snow for the Game of Thrones fans. I know nothing. I hope that you'll forgive me when I do make errors, but I'll try to be helpful and informative as best as possible.
Well, humble as always, but I think you're exactly the right person to talk about this. And of course, we don't have all the answers here, but we're doing our best and to help our community to find the answers with the conditions. So yeah, let's get started with the first question, and that's why are we seeing such a sharp rise in adult ADHD diagnosis in the United States, and how do the new clinical guidelines aim to bring more consistency and accuracy to these diagnoses?
Whenever I talk about ADHD, and I hope you'll forgive this, Nada, I like to emphasize something to listeners as unfortunately in the world of psychiatry, ADHD remains to be one of these diagnoses that's still called into question. Is it really a problem? Is it really a condition? Is it just someone being lazy? And the reason I like to bring this up is because I hope for the listener I can establish a minimum agreeable standard as to how it is we make diagnoses in the world of psychiatry, and why this applies to ADHD and the suffering from ADHD, and then we could talk about the sharp rise. So first of all, in the world of psychiatry, we've, based on the APA, the World Health Organization, the NIMH, classically defined mental illness as a combination of symptoms, typically in emotion, thought, or behavior,
Mm-hmm.
and distress or dysfunction. So symptoms and distress or dysfunction. You could have symptoms uh, like I don't know. My wife always makes fun of me when I give examples about nose picking. But let's say your symptom is picking your nose.
Okay.
But if you don't have distress or dysfunction,
Mm.
you're not bothered, those around you aren't bothered, it's not negatively impacting your life, then
Mm.
your nose picking is not a disorder or disease. In the case of the conditions we have in the world of psychiatry, such as depression, anxiety, ADHD, there are a
Mm.
constellation of predefined symptoms that represent what we typically see in a cohort of patients that kind of closely resemble each other. And due to those symptoms, have either suffering
Mm.
direct to them or are uh, witnessing negative impact in their own life that then leads to treatment. Now, I said individuals that kind of closely resemble each other because the reality is in the world of psychiatry, our diagnoses are heterogeneous, meaning
Mm.
no one diagnosis represents just one clear underlying cause. There are multiple things that cause ADHD, as we're talking about ADHD, and what we call ADHD can represent so many different things. And if it was just one thing, then we would get closer to a more definitive, consistent treatment. Um, that is not to undermine a later statement, which I'll make about the mainstay treatment of ADHD, which is very effective, but that also isn't in contradiction with what may feel like cognitive dissonance, the fact that ADHD is heterogeneous, and if it was a homogeneous entity, our treatments would likely be much more targeted and effective.
Mm-hmm.
Regardless, so symptoms, distress or dysfunction. In the case of ADHD, you have the inattentive and procrastination symptoms and the consequent outcomes. But inattention, procrastination, hyperactivity, impulsivity, that's all just a character flaw. And boy, oh boy, wouldn't it be great if it was? Because then you could perhaps do something behaviorally to consistently help people. But unfortunately it isn't the case. As you know, Nada, I'm an
Mm-hmm.
AI person, and I occasionally peruse Reddit about the latest AI trends. And the other day,
Mm-hmm.
I saw a Reddit post that went something along the lines of, I recently asked ChatGPT what it would do if it were the devil and it wanted to ensure a person did not succeed in life.
Mm.
Please look this up. I'm not making this up. This is a true Reddit thing that someone posted, and I reproduced it with ChatGPT.
Mm-hmm.
Incidentally, 4 of the 8 things that came up were procrastination, time blindness, avoidance, um, ADHD symptoms.
Oh my
So,
God.
how is it that you prevent someone from succeeding in life, not just professionally, but
Mm.
personally?
Mm.
Uh, Give them ADHD symptoms.
Oh.
Uh, ADHD is a real condition. And, we're not even talking yet about the fact that it is uh, one of the most heritable behavioral health conditions in the world of
Yeah.
psychiatry.
Yeah.
Uh, it is a real condition and it causes real problems. It cuts people's lives a little bit shorter. Uh, Treatments for ADHD improve survival rates and
Mm.
all cause mortality in
Mm.
individuals who have the condition.
Mm.
So that's my preface. It's a real condition. If I hope at the very least, if you're uncomfortable with acknowledging that it's a real condition, that your discomfort uh, apply to, unfortunately, to the world of psychiatry as a whole, because at least that doesn't mean we're biasing ourselves to just this ADHD space,
Mm.
uh, and do something about it. Ask for better ways for us to study our conditions. Ask
Mm.
for more government funding, which is desperately needed right now to improve our understanding of what will hopefully be eventual homogeneous conditions as opposed to heterogeneous conditions. Uh,
Mhm.
so ADHD, very real. Why do I preface this around the spike in ADHD diagnosis and ADHD treatment? Well, because if you believe that ADHD is not a real condition, or its treatment is a mere source of abuse and nothing more,
Mm.
then the spike in diagnosis and treatment is a
Mm.
really bad thing. Rightly so.
Mm.
If we're increasing the diagnoses of this thing that isn't a real condition, that's a problem.
Mm.
Uh, that is not my belief.
Mhm.
I do think there are misdiagnoses rates in the world, not just of psychiatry, but of healthcare, and that uh, is innate to clinical evaluations on the whole. Uh, we have no present 100% sensitive and 100% specific test for the evaluation of any behavioral health condition. What does that mean? That means there is no test that allows me to say with definitive certainty that the patient I am seeing, who I think has depression, anxiety, or ADHD, truly has depression, anxiety, or ADHD.
Mm.
That is the clinical problem. That is a problem of clinical care, and will remain to be a problem of clinical care well into the future. It's not a problem that AI will solve for the AI enthusiasts out there.
Mhm.
Uh, so going into with my circumstantial thought, the spike in ADHD diagnoses, the short answer is access to care. Uh, the reason we saw an increase in ADHD diagnoses, and the CDC did a report on this by late 2023, roughly 6% of adult Americans were diagnosed with ADHD, 50% of whom were diagnosed via telehealth. Uh,
Mm.
Now, does that mean that all of those individuals received treatment? Absolutely not. Only 30% of those individuals were on the first line choice. And this is not based on Mina Boazak's opinion. This is
Yeah.
based on almost every single international guideline that exists on the topic of
Mm.
ADHD treatment. None of
Mhm.
them were on the first line treatment of choice, which are stimulant medications. Or not none of them, only 30% of them
Mhm.
were on first line treatment of choice. Why is it that that's the case? Well, 70% of them reported having difficulties with access to treatment. A challenge that has related to supply chain management.
Mm.
And we've seen a lot of back and forth between pharma and the DEA about who's responsible for what, without clear solutions being developed to address the problem.
Mm.
Uh, so the spike is due to improvement in access and care. I would posit that there is no clear evidence that the increase in access to care has resulted in a change in the proportion of misuse or divergence of the medication. So I want to be clear about that word proportion, not absolute counts.
Mhm.
If I have 100 people, and I said earlier, sensitivity and specificity. So say I'm able to diagnose with certainty 90% of those individuals. That leaves 10 people being misdiagnosed with, let's say, ADHD, who then
Mm.
I go on to treat with the first line treatment if I'm following guidelines.
Mhm.
Well, what if another 5 people so 5%, are malingering. They're faking symptoms, and I only catch one of them. So 1%. Let's not complicate the numbers. So 5% are malingering, and I don't catch any of them. And I also treat them with the first line treatment of choice, which is stimulant medication. Unfortunately, that means there are 15 people, 5 of whom are abusing the medication, and 10 of whom uh, think they have the condition when they don't, who are on a treatment that doesn't represent the best treatment option for them. And I would posit that malingerers are suffering with something. It's not ADHD, and perhaps there should be some form of therapy that happens with them, but the treatment for them is not stimulants. Um, what if I increase those 100 people to 1,000 people? Because 1,000 people now have access to care. Well, if my error rate is still that 15%, then 150 people
Yeah.
fall into that category of receiving the wrong medication. So the problem here is not an issue of we have more proportions or a higher proportion of abusers, but we have an absolute increase of misdiagnoses and abuse rates. The Where we struggle then is societally, we haven't decided what it means to increase access to care and whether or not we're willing to take on the consequences of treating an additional 850 people when we know that the proportion change in malingering will not change. So if we want to say, hey, we're not comfortable with an additional 135 individuals being treated with the wrong medication, then we're also necessarily uncomfortable with the additional. I'm not going to do the math well enough, but call it 700 and I think it's 65 individuals receiving care. It's not a telehealth issue that we're struggling with. What we're struggling with is a healthcare system that has imperfect beings and imperfect diagnostic processes, which will remain to be the case well into the future as we continue to slowly iterate upon that imperfection. Um, so it has these imperfections, and we're struggling with what our tolerances as a society for what it means to broadly increase access to care, despite that meaning that will also mean a proportionate increase in misdiagnosis rates and a proportionate increase in access to the malingerers. I hope what I said just made sense, but ultimately, the short of the long of it is the reason we're seeing increases is because of access.
Because of, yes, and that would be, I would just quickly reflect and try to summarize. So first and foremost, ADHD is a real condition. So it's not a character flaw, although it would be very convenient that it is, but it's not. And it's good that people have access to care, to access to diagnosis, access to medication. But with that, because diagnostic is not perfect, humans are not perfect, there is a room for error, and there will always be a proportion of people who will be receiving treatment that it's not supposed to be for them. So I suppose it will always be a possibility and it will always be happening. But this shouldn't affect the majority of people who actually do need the care. So that's my understanding from everything that you said, and probably the professionals and people working in mental health space probably should be advocating for the for profession and for their patients to get proper access to care. Maybe that's one of the answers here.
Oh,
Yeah.
100%. And
Yeah.
I would, so it is my opinion
Mm,
that, and not just my opinion, but certainly most of the medical societies in the United States that have come out
mm,
to comment on what we'll soon talk about, which is
mm-hmm.
regulations around
Yes.
telehealth,
Yes.
uh, that access to care in and of this itself is not a bad thing. And what I'm
Exactly.
saying isn't, hey, our diagnoses processes in
Yeah.
the world of healthcare are imperfect. Let's just
Yeah.
accept it willy nilly and that's it.
Yeah.
No, we what we need to do is identify the real causes of the challenges before us and work to address them
Mm,
in a fashion that truly moves towards improvement, as
yeah.
opposed to a fashion that uh, artificially minimizes absolute counts and
Mm,
limits access to those who truly suffer. The reality is, outside of the world of ADHD,
mm,
outside of the world of patients who are managed with scheduled medications, there are still imperfect diagnostic processes,
yeah.
and there will still be an absolute count of individuals who receive medications that they should not be receiving because our diagnostic systems are imperfect.
Yeah.
Uh, the the discomfort with scheduled medications is due to safety, certainly,
Mm,
and we could minimize the risk
yeah.
by implementing systems that minimize the absolute counts that any
Mm.
one person receives, certainly at the start of a clinical relationship.
Thanks. And yeah, I would definitely move on to the next topic, and that's the role of telehealth in making the ADHD evaluations and treatment more accessible, which we said it's not a bad thing, it's a good thing. And this is especially important for adults who may not have sought help otherwise.
Telehealth most certainly is the reason, is the large reason for the spike in ADHD diagnostics and treatment since the COVID era. Uh, the one thing that I don't see discussed as often that I've witnessed in my own patients is um, what's also leading more ADHD patients, adult ADHD patients, to approach and require care since the pandemic. It, is the transition in the way we do work and the way we do life. A lot of people are now working from home, and the consequence of that for most individuals with ADHD, even though I know some of you out there are gonna disagree with this, um, is for most individuals, it leads to increased distractibility, a reduced sense of accountability due to the manager or colleagues being nearby, and a shift in what would be called the Yerkes-Dodson curve, which evaluates sort of the stress to productivity bell curve that leads to reduced overall work being done. Uh, so there's been a shift due to this move of work from the workplace to working from home.
Mm,
Certainly, with the right accommodations, those types of things could be addressed, but I do think there's also an element there. Telehealth has been tremendous in improving behavioral health care access on a whole. In the United States, we have the world of behavioral health has one of the largest disparities in care access. And that's only expected to increase over the next decade. Consequently, what that means is for many individuals, they may find themselves in regions where they have no access to a provider, or if they do have access to a provider, the timing of a visit that they can have with the provider, or the travel distance to and back from the provider to their work, is just so long that it makes it really hard for them to engage
Mm.
in behavioral health care. Uh, you compound ADHD symptoms on that, time blindness, procrastination with scheduling one's visit,
Mm.
a tendency to be late for everything. And then you have patients who, even if they get to the point of scheduling a visit, odds are they're going to be so late for the visit that they're going to be canceled, or their visit's going to be canceled, or they just might forget their visit altogether. So telehealth for those patients has certainly improved things in that, at least, even if the patient forgets their visit, when they get the reminder text, they don't have to worry about driving X amount of time to get to the office.
Yeah.
And certainly anyone in the world of behavioral health who's either partially or fully transitioned to telehealth will tell you that the show rates
Mm.
of patients is much better for telehealth versus in-person care. Um, and that's a really good thing. It promotes treatment utilization and getting to the right treatment. It promotes safety. Uh, Amongst the things that I've personally witnessed in the world of telehealth is in the world of telehealth, we think about the subjective, actually in the world of healthcare in general, the
Mm-hmm.
subjective exam, what the patient tells me is going on, and then the physical exam. What's the physical exam for a psychiatrist or a behavioral healthcare provider? Well, it's what we call the mental status exam.
Mm.
And it's things like the appearance of the patient, their behavior, their speech patterns, their affect and mood. One thing that I've begun incorporating in my thinking of the mental status exam that we hadn't had in the past is the environment. The patient's
Mm.
environment has become diagnostically relevant to me, because if I see their home, I know what things are looking like.
Mm.
If they're telling me they struggle with chore management and are unable to keep up with cleaning their environment, and they're in a pristine place, and yes, I do ask them to move the camera around if they're comfortable with doing so. Then that allows me to get a better picture of the possibility, and it doesn't necessarily always mean that the patient is making up symptoms, but the possibility that there's some discordance there, and I could talk to the patient about it. What about pill counts? Well, it's amongst the things we could do to minimize misuse rates of high risk medications is to do pill counts. Does the patient have as many tablets or capsules of whatever the medication is as they should, based on when I last prescribed the medication? The patient isn't always going to remember to bring their medication to the office during visits. But if you're meeting them from their home environment, that's something you could definitely do. And if the medication isn't there, that certainly presents itself an opportunity for discussion and an evaluation by the clinician. So yes, telehealth has played a tremendous role in improving access to care. It is my strong opinion that
Mm.
for the most part, there are certain exceptions. Telehealth is equal to, and in some instances superior to,
Mm.
the in-person evaluation for clinical care. And in my opinion, that is definitively true for most of my ADHD patients.
Mm.
Some individuals will ask about urinary drug screens. Well, there's nothing stopping me from inputting a urinary drug screen lab for a patient that I see via telehealth. I just ask them to go to their LabCorp, their Quest
Mm.
Diagnostics, or their PCP office. Um, in terms of vitals, we certainly are lucky to have information route to us through the Health Information Exchange, and we have primary care vitals in addition to primary care notes. But we can also ask patients to collect their vitals with cuffs that they could get from Walgreens, or collect them from their PCP. When I first started, it was my goal to send blood pressure cuffs to all our patients, though that eventually proved to be a costly endeavor given that our margins are generally tight.
Mhm.
But they, again, I can't emphasize the extent to which telehealth has been important.
Yeah. And we as practice figure out the way to collaborate with other providers to allow us to get the measurements of physical health that we needed. So there is always a way to find. And I think what you shared here was very valuable. I personally didn't think that you could figure out based on talking to someone online. So I think this was very valuable discussion. And I would like to continue with the next question, which continues this discussion, and that's DEA proposed a requirement for in-person visits before prescribing controlled ADHD medications, and I think that that can affect the access to care, particularly for people who live in rural areas or undeserved areas. So, what's your opinion on that situation?
I think based on what I've said so far,
Mm,
I bet most individuals could guess that I'm a fan of telehealth,
yeah.
and in most instances, think that telehealth is equal to in-person care. Uh, let's first talk about where the DEA is coming from
Mm-hmm.
and what the DEA's goals are, because I think the the goal is well founded. The means or regulations they're trying to develop to meet those goals are misinformed. The in person requirements actually predated COVID era flexibilities, and they were based on this act called the Ryan Haight Act. And that act was developed in the early 2000s based on a young man, Ryan, who was 18 years old at the time and managed to get a provider he never saw to prescribe him Vicodin and to have that Vicodin shipped to him via an online pharmacy. And Ryan, who is based on, I read a little bit more about him, although he comes up on the regular when discussing the Ryan Haight Act. Who was a straight A student and well regarded in his school, ended up overdosing and dying due to the Vicodin overdose.
Mm-hmm.
Uh, the Consequently, the Ryan Haight Act was developed to protect individuals from malicious prescribing and dispensing patterns. Uh, this was in like early-ish era of the internet,
Mm-hmm.
before we had, and most certainly early era of electronic health records and reporting requirements. Before we had a strong prescription drug monitoring program, uh, things look significantly different now. There is I cannot put in a uh, single, and at least in the state of North Carolina, in fact, most, if not all, states in the United States, the prescriptions, the scheduled substance prescriptions you put in, are reported and easily tracked. Besides which, there are strict regulatory requirements regarding uh, your responsibilities as a provider to check prescription history for patients you see for whom you prescribe scheduled substances. There are strict requirements and ethical standards around the need to do a comprehensive clinical evaluation of patients before prescribing any medication, including scheduled substances. So why the in-person requirement now? And what is the requirement now? Well, so you guys are aware. I'm sure some of the listeners are receiving ADHD care and stimulant management despite maybe never having seen a provider in person. And that's because since COVID, the DEA, under the national emergency, has put in pandemic era flexibilities that basically say you don't need to see a provider in person for them to prescribe a scheduled medication to you. That's set to expire at the end of this year. And starting next year, we're going to go to one of two areas. Right now, the DEA has a set of proposed rules that still haven't been finalized. We're going to find out in the next month or two what they look like. Uh, and if those don't get finalized, then we might see the older Ryan-Haight Act rules, which is that rule requires providers to see the patient at least once in person, period, prior to prescribing a scheduled medication. Sounds simple enough, but for those patients that live rurally, it's just not tenable, and just from a clinical perspective, for many patients, it's unnecessary. Like it's just a checkbox exercise that, in my opinion, doesn't protect patients against much, because malicious providers can still document that they saw the patient in person. If someone is malicious enough to prescribe to a patient a scheduled medication despite not having seen the patient or done a thorough evaluation of the patient, then what's to prevent them from saying on a piece of paper, which they document, that they saw the patient in person? Um, this is restrictions on the honest providers. So regardless, so we're either going to go to the Ryan-Haight or to the new rules, and the new rules sort of introduce a little bit of flexibilities, but not really. There's an advanced registration pathway that allows some providers, psychiatrists included, and board certified NPs and PAs, to prescribe Schedule II medications, stimulants included, for 50% of their patient load. So if you're, or sorry, 50% of the Schedule II medications must be under the, or can be under the advanced registration, which means the other 50% still require an in-person visit. So it's arbitrary. Like, why?
Yeah.
What their thinking is somehow it protects people, but does it really? I just, it doesn't make sense.
Sense. Yeah.
The other concerning thing is they're basing their judgment on what they're calling the next opioid epidemic, relating to stimulant use increases, or stimulant abuse increases, which, by the way, are due to an increase in methamphetamine use and stimulant spiked fentanyl, not relating to prescription stimulants. So yes, methamphetamine can be prescribed, but I don't know of a single provider who prescribes methamphetamine. So they're basing their judgments based on that, and saying broadly, stimulant medications, which we use for the treatment of a well-known, well-documented condition that causes significant life-altering distress and dysfunction, we need to apply restrictions on that. So they're proposing those rules. What will those rules result in? Invariably, it will result in a decrease in access, without question. And that decrease is going to significantly impact our rural populations, individuals who are underprivileged. Why? Because even if I live in a city with psychiatrists, I'm not going to be able to leave my second or third job that I'm working today for 2 hours to drive to them, get seen by them, and drive back. And for ADHD patients in particular, you still have the issues of procrastination, forgetfulness. So yeah, we're going to see reductions. Besides which, I can't emphasize this enough, it
Yeah.
is my strong clinical opinion, based
Mhm.
on my personal clinical experience, that if anything, uh, clinical evaluations, when done properly via telehealth for ADHD, result in better diagnostic assessments, allow me to do more consistent pill counts, and allow me to do a more thorough evaluation of not just the patient, but their environment. You
Yeah.
can ask them to bring in family members if they're comfortable, and their family members are often in their own house. Um, so, all that's to say is it's unnecessarily going to reduce
Mm.
access to care, at a time where tragically we could provide the care to the patients that need it, but yeah, are unwilling to.
We heard you loud and clear. So, and hopefully there are more clinicians out there advocating for um, just better accessibility to the care. I think that's the goal. I think next question is kind of reflection on it, on what we were talking about right now. Um, I think those regulations, their intent is to safeguard and recommend the bonds in accurate diagnosis and um, prevent the risk of overdiagnosis, especially in online and telehealth based settings. But based on everything you said right now, I don't think that's necessarily what you think is going to happen, but maybe we can reflect on these safeguards and the rules, and what are they going to bring.
Yeah, so the safeguard essentially is a restriction in access for
Mm,
those that are going to be evaluated via
yes.
telehealth.
Yes.
Uh, the presumption, therefore, being that I am only able to predict misuse or abuse patterns in individuals I see in person as opposed to those I see via telehealth. Based on my experience, the logic doesn't hold
Mm,
well. Uh, the rather, my sense is, if we truly want to see improvements or reductions in prescriptions to potential malingering, um, or misusing individuals, then we have to implement those things or those systems that we know to be working
mm,
or to have worked. In the DA's new proposal, incidentally, one of the things that they did not definitively say would go into effect next year is a national prescription drug monitoring program, as
mm,
opposed to
mhm.
what's being done now, which is state level prescription drug monitoring program. That would help. Requiring providers to monitor their prescription drug monitoring program, not just prescribing providers, but dispensing providers like
Mm,
pharmacists, is an important step to ensuring individuals are safe.
yeah.
One thing that, amongst the many, that would be great to ensuring patients are safe is including an attestation, because at the end of the day, this
Mm,
is, in everything we do, we're essentially attesting to having done XYZ.
yeah.
So the underlying presumption is, if the individual is attesting, then hopefully they've done this.
Yeah.
Requiring an attestation to misuse, diversions, or substance abuse
Mm,
screening. So has the provider who is prescribing a scheduled substance that can potentially be abused screened the patient for substance abuse?
mm,
And if the patient does have a substance abuse history, and the provider then moves forward with prescribing the medication, what is the justification?
yeah.
Uh, to be clear, in the case of ADHD, stimulant treatment for individuals with ADHD tends to actually reduce substance abuse rates as opposed to increase it. Um, it though that doesn't negate the necessity to do a substance abuse screening and to ensure that the individual isn't abusing medications that could be deadly in combination with stimulants.
Mm.
The next item is I mentioned pill counts a couple of times.
Yes.
Pill counts, if you're concerned about someone misusing or diverting their medication, then that is a basic thing. It doesn't take a lot of work to have an individual count their medication with you.
Yeah.
So why not have providers document that?
Mm.
Instead of um, having requirements that don't appear to have clinical justification behind them. My sense is
Mm-hmm.
what the DEA is trying to do is minimize the absolute count, which we talked about earlier,
Yes.
of individuals receiving the wrong medication. But the cost of that is most certainly an absolute reduction of people receiving appropriate care. And that's like saying, we have 1,000 people who have a gangrenous leg and need an amputation. But because we know five of them are unfortunately going to have the wrong leg amputated, or 5% of them are going to have the wrong leg amputated, then we're only going to treat 100 of them and let the remaining 900 have happen to them, whatever happens to them. I just that doesn't sit well with me. Uh,
Yeah.
so there are certain things you can be done that can be done. Urinary drug screens, I think, are a good way to evaluate for misuse, diversions, or certain substance abuse. Some of the time, I don't. So many guidelines do not blanket recommend urinary drug screens. If the DEA feels it necessary uh, to minimize risk, then blanket UDSs certainly may help.
Mhm.
It's better than the current in-person proposal.
Yeah.
Uh, and then, just from a standard care perspective, you also need to document um, a full and comprehensive clinical evaluation.
Yeah.
Hey, does the DEA want to know if you've done a comprehensive clinical evaluation? Um, Ask the provider how much time they spent with the patient. Let's be realistic. There are
Mm-hmm.
some intakes out there, some clinics that do 10-minute long diagnostic assessments, prescribe a medication, and that's it.
Mm.
Um, Nada, I'm
Yes.
super proud of what we've made
Yes.
or what we've built here at ASP. Our intakes are 75 minutes in length. I know we advertise them as 50 minutes, but in fact we schedule 75 minutes of time for the provider just in case the intake needs to go long. And we
Yes.
emphasize to our providers that first visits don't need to result in a diagnosis or a diagnosis if you're not certain of what's going on. Have the
Mm.
patient come back. We need to make sure we're doing
Yeah.
comprehensive assessments. Our
Yes.
follow ups are 30 to 45 minutes long. We take our time with the patient. Does that mean reasonably shorter visits don't result in adequate care? Absolutely not. But I could tell you that a 10-minute intake, a 15-minute intake, is not going to lead to equally accurate differential diagnoses as a 45, 60-minute intake or longer.
Yeah.
Uh, so, can we just look at how much time the providers are spending with their patients? That's a good way to evaluate the quality of care,
Yeah.
not to limit access.
I think following good practices and implementing them to these rules might be a better solution than restrictions, if I understand this correctly. So there are solutions out there, and if the lawmakers would just sit down with clinicians, especially those who are providing exceptional care, there could be solutions and for everyone involved, and most importantly, patients for their
Mm.
benefit. I would like actually to um, reflect on the impact of these rules to women, minorities, maybe people and adults who are late diagnosed, and then we can talk about some solutions and best practices in telehealth. So, with everything being said, what are your thoughts about those groups that I just mentioned and how the potential new rules would affect them?
So we know that since the COVID pandemic, the largest increase in ADHD diagnoses was in adult women between the age of 20 to 29. I
Mm,
think that was the age group. And a large proportion of that diagnostic increase is due to increase in access through telehealth. So,
yeah.
likely, what's going to happen is in restricting access, we're going to see women in particular within that age group disproportionately suffer due to losing access.
Mm,
In terms of minority populations in general, we know that the Hispanic and Black population uh, tends to be underdiagnosed as compared to
yeah.
Caucasian patients with ADHD. So I'm not sure that we have much data. There may be out there
Mm,
demonstrating that telehealth leads to increased diagnostic rates for that population in particular. What I can say is um, the financially underprivileged minorities will probably see a significant impact again due to that challenge of, well, they just don't have the time to go to the
yeah.
appointment, do the appointment, and then come back from the appointment. It's one thing to have a 1 hour appointment, it's quite another to also have to do the 45-minute drive, the wait, and the 45-minute drive back, or the
Yeah.
20-minute drive, the wait. Um, so, yeah, there's definitely going to be a disproportionate negative impact on minority communities. And that's not even to say that the access deserts. So there are plenty of rural communities out there who just have zero psychiatrists nearby. Oh, and by the way, the DA flexibilities, so that who tends to provide care for those patients, it tends to be primary care provider, but
Yes.
the DA special designation, or the advanced special designation, doesn't allow for primary care providers to register. So that then is sort of a double whammy for the rural community patient.
Yeah, it doesn't sound good, but yeah, hopefully there will be some solutions because lots of people will be affected. So I would like to now look ahead and maybe discuss how can policy and technology and clinical standards work together. I think we touched on this, and you were kind enough to provide already some solutions. But let's maybe summarize how all of these factors can work together to ensure that adults with ADHD have the care that will remain both accessible and high quality in and preferably largely in the digital healthcare landscape, because as we could see, it's not just the future, I believe it's the present and should be the standard of the care.
Yeah. So we're already seeing part of that.
Yes.
Why telehealth care is safer now than it was 20 plus years ago when Ryan died
Mm,
is because we have state level and hopefully soon national level systems
yeah.
that allows us to monitor prescribing practices and other data elements if we want to collect those other data elements. The benefit of technology is broad. I'm sure eventually we can have AI evaluation systems that will conduct better evaluations than a human can of potential malingering due to inconsistency patterns or misuse patterns. I'm also sure that if a strong enough investment were to be put in, we can add additional data elements to our prescription drug monitoring program to evaluate for some of the things that I mentioned earlier, that would improve or reduce prescriptions going to high risk patients. Ultimately, what it comes down to is our technology allows us to document in a fashion that is now more than ever easier, allows for easier data ingestion. Our ability to evaluate the data and report on the data due to a combination of fantastic business intelligence solutions, and the support of AI in architecting solutions is easier than it ever has been.
Yeah.
And our knowledge clinically of what works and what doesn't is also 20 years ahead of where we were.
Yeah.
And we know that in general, telehealth works, and the malicious actors aren't malicious because of telehealth, but despite it. And they'll continue to be so even if we remove
Yeah.
telehealth flexibilities. Ultimately, I think to truly protect patients from the malicious actors, and by that I mean prescribers and dispensers, what we need is some form of automated system that captures a true encounter. And that's most certainly more possible to do via the virtual world than it is via the in-person world. I'm meandering because I think there still is some work to be done, but what can be
Yes.
done is going to be much easier in the telehealth world.
Absolutely, 100%. We can wrap up now. And if there is maybe one thing that we can take away from this episode, I would say I would address both our patients, people maybe living with ADHD, but also the lawmakers. I think it's important that everyone have some takeaways from this episode. What would be your message to both of these groups?
Yeah, access does not equal maliciousness. Remember that proportions are different from absolute count, and access isn't bad. We're improving access to care. Let's not go backwards.
Thank you. Thank you so much. It will be interesting to see the next couple of months how the situation will change and how the practices, including ours, will adapt, and then patients as well. And I'm sure we will continue advocating for the access of care. That's 100%. So thank you so much, Mina, for joining us. Thank you for sharing your opinion on those important topics. And let's hope everything will turn out for the best for our patients.
Thanks, Nada.
Thank you for listening to Thriving with ADHD. This show is produced by Animo Sano Psychiatry. Please follow, rate, or share our podcast on Spotify, Apple Podcasts, or any other streaming app of your choice. Music is by Daddy's Music from Pixabay. For more information about Animo Sano Psychiatry, please visit animosanopsychiatry.com.